Hello and welcome to Equalise, the ESRC Centre for Lifecourse Health Equity. Equalise is a £9.6 million research centre funded by the Economic Social Research Council from 2025 to 2030. The centre is led by Professors Yvonne Kelly and Anne McMunn and based at the University College London. Our work focuses on tackling health inequities, systemic, unfair and avoidable differences in health, using mixed methods and interdisciplinary research. We are engaged in partnerships with over 30 organisations from higher education, government and the third sector. If you're interested in our work, please contact us via email at equalise@ucl.ac.uk. Thank you for engaging with our work and we hope you enjoy the session.
Thank you everyone for coming for our Equalise Method seminar. Today we are so pleased to have our Equalise colleagues, Professor Yvonne Kelly and Professor McMunn, to talk about the importance of considering time. And I really like the title of this presentation. So the title is "Time is on my side." Yes, it is.
Slightly different emphasis.
So we can't say much about health inequality without considering time.
Chronic lung disease and housing conditions in early childhood, cardiovascular disease and early life nutrition, premature mortality and social isolation in the adult years. All powerful observations that have emerged from the analysis of observational studies, all of which have clear policy relevance. Just a word on the ask. Anne and I were invited by the method subgroup to reflect on nearly a lifetime of using quantitative data resources, large social surveys, and some of the key considerations we have when we're looking at these kinds of data, and also to show some policy relevant examples of the kinds of data analysis that we've done and the findings that we engage with. So thinking about time is incredibly important, and over the last 50 or 60 years or so across epidemiology and the social sciences there's really been this sort of blossoming in life course studies, and we really have to consider time in all of our life course studies to make them relevant for policy, and it's obviously incredibly important when we're trying to find solutions towards health equity. We're thinking about time in a number of different ways, and we'll keep on returning to this theme throughout the talk, hence the title. So the first kind of, as a sort of a starting point, time is important in terms of temporal ordering. So ordering is incredibly important. Chicken and egg, what comes first? So we really need to get the order of our exposure and our outcomes of interest, generally health we're concentrating on today. In order to disentangle what could be social causation and what could be health selection or selection effects. So that's one thing. The first thing is ordering. Secondly, how long? So dose and duration are incredibly important, and we often talk about accumulation. Again, we'll come back to that later in the talk. Is the length of exposure to a given thing important? Are outcomes worse? So we might think of there, for example, airborne pollution. So the longer we spend in polluted environments, is it worse for our health in a number of different ways? The answer is usually yes. Next about time is part of the when. So when in development and decline, we're exposed to a particular event or insult, and we can imagine that this has different impacts potentially, whether it's during those developmental years through childhood and adolescence, or whether it's one we're on our steady decline from our sort of third or fourth decade onwards. Incredibly important is that part of the when. Also important in terms of the when is historical time. So here we're thinking about when things happen, social norms or events that occur in particular periods of time and lead to period and cohort effects. But again, we'll come back to that topic in a bit more depth a little later on. So now thinking about observational studies. So we tend to, social researchers, health researchers, people in policy fields often think or often feel that the randomized controlled trial is kind of the gold standard in terms of thinking from causal perspective. But when we're in the social sciences, it's often unethical to randomize people to various social exposures. So, for example, social smoking in pregnancy, or physical punishment in childhood, or social isolation in older ages. It's simply unethical to randomize people into those sorts of groups of exposure and not. So animal experiments as another option, but we know that social exposures in animals will simply lack relevance in terms of human societies. So we then struggle to generalize any findings from animal experimentation to human settings. So along come the observational studies, because carefully designed observational studies, high quality observational studies, really can help inform questions around causality. And we do that in a number of ways because of the ways in which the data collected are usually often very detailed, often very broad, and help us to go about inferring causality for a number of different reasons. And I've got 6 of those listed on this slide. Firstly, that temporal ordering. So the really getting the timing is absolutely key. But observational studies allow us to do that because they often follow the same people over a number of years. So that longitudinal aspect of the kinds of data that we use overcome some of those limitations of cross-sectional designs in terms of being able to ascertain a direction of association. Replication is also key. So here we're looking at associations, the same association. Does it hold in different settings where perhaps the distribution of social factors are different across 2 different settings? And I'll come to an example of that later in this talk. Being able to take account of multiple competing explanations is another key advantage of large-scale observational studies, because we can factor in a number of different aspects of the environment that might otherwise be driving associations. So we can kind of take account of those. Fourthly, natural experiments. So here we can exploit public policy changes, for example, sugar tax on the risk of obesity, changes in the minimal school leaving age back in the 1950s and so on, and then lifetime earnings, et cetera, et cetera. And in Equalise, certainly we are looking forward to dipping our toe into some of these kind of natural experiments scenarios. Fifthly, a really enhancing observational studies of these large-scale social surveys is the opportunity, which of course we are taking in both hands in Equalise, to bring in a mixed methods approach, because combining these large-scale data with the insights from qualitative research really is the key to deepening insights and getting closer to causal processes and those all-important ways of informing solutions towards health equity. And finally, I put the strengthening relationships, working with a range of stakeholders. Again, we're working hard to do this in Equalise, from people right across a number of different constituencies, communities, policy influencers, advocacy groups, and so on, and learning from them partly about how to interpret some of our findings, but also how to place those in the policy context, which is of course key in our aim to identify solutions, or at least inform solutions. But there are challenges. When every rainbow, there is a cloud lurking somewhere. There are challenges, and we have to be really careful about how we take account, or how we consider some of these challenges with these large-scale observational study designs. The data themselves are collected over years and often decades, which make them incredibly labour-intensive, expensive to fund, and also put a particular burden on participants. So that's one drawback. Secondly, missing data and attrition Sometimes people drop out. Sometimes they don't answer all of the questions you ask them. How dare they? And sometimes they pop back into surveys. So we have attrition and missing data for a number of different reasons, which we have to take account of. Thirdly, measurement. Measurement, it comes in all sorts of the challenges here in all shapes and sizes. So relevance is the first one we'll touch on. We put a measure into a large scale social survey, and is it future proofed? How out of date will it be? How relevant will that be to our research in the future? Sometimes the second part about measurement is sometimes we don't ask questions about really important things. In fact, often we don't ask questions about really important things. And an example of this from right at the beginning of my career was the 1946 birth cohort not collecting data on gestational age. So they had birth weight, but they didn't have gestational age. So in the mad flurry of work that was taking place in the late 1980s and early 1990s, trying to look at associations between infant growth and a whole host of chronic disease outcomes, we didn't have gestational age, we couldn't factor that in. So sometimes we don't measure things that are important. And thirdly, on measurement, sometimes our measures are imprecise. Well, no, not sometimes, but often we are measuring, we've got proxy measures, or we've really got quite vague, woolly measures of the underlying construct that we really want to tap into. So there's a lot of imperfections there. Another challenge is around well, I think we're actually doing a lot better than this. So listed fourth there is thinking causally in terms of temporal ordering. We have revolutionized epidemiology we've dragged ourselves into the century by now adopting DAGs as just a point of habit in any analysis we do. So we are thinking very, very carefully about that temporal ordering and explicitly from the get-go. The fifth challenge is the messiness of life, because let's face it, life is messy, it's complex, trying to factor in all of the different dynamics that are occurring within individuals, within households, across regions and societies. So life is incredibly complex, and we have to somehow factor in that complexity to our analysis. Well, we do the best job that we can. And finally, here in terms of challenges is unmeasured confounding. So there are things that we don't factor in, but again, we are becoming a lot better at that these days with the advances in causal inference approaches. But sometimes if we don't factor, or if we don't take account of unmeasured confounding, then that will lead us to spurious results, which of course is detrimental in multiple ways. So I'm just going to step back now to age, period and cohort effects, back to our friend time in a bit more detail. We are a bit obsessed with these in epidemiology and social sciences. I'm just going to show you a couple of examples of how these might play out. So age, as I've already touched on, is important in terms of development and decline. We might accept in general that across a life course, the risk of chronic disease and mortality increase. Well, that's certainly true in adulthood. We know if we look at childhood and adolescence, actually, we see a downward trend in mortality. But age is important. Period, here we're looking at events typically that are occurring at some point in history. Good examples are things like conflict and wars, pandemics, we've just recently had one of those, recessions, that sort of thing. So we can use those period effects to help us understand different aspects of what we might be seeing in our data. And finally, cohort effects. These are things, events that affect a generation. So these are a group of people born roughly within a sort of a 10-15 year time span. So these events will affect cohorts in distinct ways. Separating those out is incredibly important, especially if we're trying to identify policy solutions. A nice illustration on this next slide is just taken from the Centre for Longitudinal Studies website, so thank you to them, where they show it's a real clear example of the growing importance of the obesogenic environment across generations, so across the cohorts, the 1970, 58, and back in time 46 cohorts. And here you see the age at which the majority of the population, men on the left, women on the right, became overweight. So from left to right, the most recent of those birth cohorts, 1970, the majority of men became overweight at age 30. A little bit older in the 1958 and 46, so 34 years and 41 years respectively. Women, they're on the right-hand side and above the line, the blobs, a little bit older before they, the majority of those became overweight. So 41 in the 1970, up to 48 in the 1946. So it's a really nice, clear illustration of how environmental change is affecting overweight and obesity across these generations. A small extension of that on this next slide brings in the dimension of age, which I think is interesting. This uses data from the 5 birth cohorts. So in addition to the 70, 58 and 1946, we have data from ALSPAC and a bit of data from the Millennium Cohort Study as well. The key takeaway from this slide, which is quite busy, and there's a line for each of those birth cohorts, is that the probability of becoming overweight is younger, at a younger age, than for the more recent cohorts. So for example, participants in MCS and ALSPAC the probability of them becoming overweight at younger ages was higher than for the older cohorts. Okay, so here we're bringing in the dimension of time, because you can see that nice developmental trajectory of overweight by age, and you can see that it's quite difficult to see in the younger cohorts because they stop at younger ages, but you get the point. In the more recent born cohorts, they're more likely to be overweight at younger ages. Over to Anne.
Okay, thanks, Yvonne. So we're going to come to saying a little bit about some of the kind of key methods that tend to be used in life course research. But before we do that, we wanted to just say a little bit about the kind of main theoretical underpinnings in life course research, just so everyone's aware and on the same page. And I think it's fair to say that historically, life course research has really developed along kind of 2 separate tracks, which have, for a very long time, did remain quite separate. So on one side, we have life course epidemiology, and I've listed Daiku and Ben Shlomo there. They wrote a series of books on life course epidemiology in the 2000s, which were kind of the books that put life course epidemiology on the map as a discipline, really. And those emerged from a time at which people were becoming really interested in the evidence that was emerging about the importance of early life and its longer term influence on later life chronic conditions. And some of that emerged from the Barker studies that people may be aware of, which were showing that intrauterine growth, Yvonne mentioned an interest in that. It was a really hot topic at the time, showing that that actually was linked with chronic conditions, metabolic disorders in mid and later life. And also the 1946 birth cohort that Yvonne mentioned as well, which was the first British birth cohort study that we had, and actually was really seminal worldwide in terms of setting up a longitudinal birth cohort study to follow people from birth until death. And those people in the 2000s were going through their late 50s, early 60s when chronic conditions were starting to emerge. And evidence from that cohort was showing, again, the importance of early life conditions. In terms of, we had the biological evidence from Barker, but also the socioeconomic conditions that people were born in and grew up in being important in the longer term. So that was the kind of background to leading to this life course epidemiology kind of discipline. And I've listed the three kind of key models that were set up in that work that we still use to this day. So those were around kind of critical or sensitive periods. So this is where there are certain stages of the life course, perhaps in early life, but not necessarily only in early life, where that is the time at which, when you're exposed to something, it will impact an outcome further down the line. So you can think of an example that sometimes uses like language development. If people aren't exposed to language early on in their life course, there's a suggestion that they actually then become unable to develop language skills further down the line. So that would be an example of a critical period. Sensitive periods are where the impact of an exposure at a particular life stage is stronger than it would be if people were exposed at a different stage of the life course. So again, thinking about early life and development, it may be that if you're exposed to, say, a toxin during your developmental period, that may impact you more than if you were exposed further down the line when your kind of immune system was more developed, or that kind of idea. Then we have accumulation of risk over the life course, which is really an additive model, just in the sense that it's sort of a question of duration. The longer you're exposed to, say, socioeconomic deprivation over your life course, the stronger the impact is likely to be. And then we have the chains of risk or pathways model, which is saying that early life, for example, disadvantage or particular circumstances might then trigger pathways of risk, advantage, or disadvantage that then influence your life further down the line. So life course epidemiology traditionally has sort of tested these different pathways, quite often looking at socioeconomic circumstances in relation to health outcomes, but actually has been extended to look at a whole range of risk factors over the life course. Kind of alongside that, then, we have social science life course studies, building on work by Glenn Elder. So Elder started this work way back when, looking at children growing up in the Depression in the 1930s in California. And he came up with these 5 principles of life course studies. So you can see with these 5 principles, there is overlap with some of the ideas from life course epidemiology. We have lifespan development and aging as lifelong processes, which very much picks up on some of those ideas, similarly to life course epidemiology. We also have the idea of timing, so the impact of antecedents of life course transitions, events, and behaviors vary according to their timing in the life course. But then Elder, really being a social scientist, kind of pulls back and looks at some more bigger picture aspects that aren't included so much in traditional life course epidemiology. So thinking more about historical and geographic context, the importance of historical times and places as shaping the life course of individuals, thinking about linked lives. So the fact that we don't live our lives in isolation, we're very much influenced by our relationships and the people around us. So the life courses are interdependent. And Elder also brought in this idea of human agency and opportunity. So not just thinking about how your circumstances structure your life and the outcomes in your life, but also what individuals themselves can do through agentic action to kind of change things or be able to be resilient, for example. So you can see that life course epidemiology takes a kind of more clinical medical model, maybe you could say, whereas Elder's a little more kind of pulling back and looking at the bigger picture. So that's the kind of background, but now nowadays we have a lot more longitudinal data available, and the discipline has really developed to become much more interdisciplinary in nature. So I think we draw across a lot of different disciplines now in life course research. So I just wanted to highlight this more recent theoretical contribution as well, which we call, well, the authors call the cube. And this is really just a kind of demonstration of the complexity that Yvonne was talking about in terms of the life course. So we often in our studies have an x-axis and a y-axis, and quite often along the x-axis we have time or age, and our y-axis will be some kind of life domain or outcome or health outcome that we're looking at. Here we have a three-dimensional kind of shape where we're looking at time on one axis over the life course, but we're also looking at those different life domains. So in our research, those might be our kind of social exposures, for example, thinking about work or family life, or those different kind of social exposures that we think about in social epidemiology. And then this third level, which is thinking about the different levels of action. So you have kind of things that are going on within the individual, which are important to processes that are happening. You have then how that individual is interacting within their kind of immediate environment at the individual level. And then you have the kind of supra-individual, that kind of macro level context being important as well. So people who are familiar with Bronfenbrenner might see a kind of nod to his work there in terms of thinking about those different levels of action. This is really complex, and I think it's purposely complex, kind of recognizing how complex life courses are. The authors say that they recognize we're not actually able to operationalize all of this when we're doing our research, but it just triggers us to really think holistically about the questions we're trying to answer. Okay, before moving on to methods, we wanted to just acknowledge these two other kind of theoretical areas that have been key to our thinking in setting up Equalise. They're not life course theories or models, but they have been important to our thinking, and I know to lots of the thinking of our colleagues here. One is Nancy Krieger's ecosocial model of embodiment. So that's thinking about the processes by which social conditions are become biological and embodied and actually influence physical health. And the other is intersectionality. So thinking about multiple social positions and how they intersect to create unique experiences of oppression, privilege, power, and how that influences health. So those are two key areas that are very complex, and I haven't done them justice, but just a nod to the fact that they've influenced our thinking in the center as well. Okay, moving on to methods. We're not going to kind of get statistical and pull out any equations or get into too much methodological detail, but we wanted to just highlight some of the kind of main methods that tend to be used in life course research, and these very much depend on the research question that you're asking, of course. So thinking about life course models, those ones that I just covered around, for example, sensitive periods or accumulation. There are different ways of testing those, but structured life course modeling approach is one that has that was developed by Gita Mishra, actually, who was a statistician on the 1946 cohort originally, and has been further developed, and that is often used to test these questions around sensitive period versus accumulation. Katie can say more on that if we want to get into that. Then one thing that's quite often done in life course research is modeling trajectories, because we are interested in change over time. Quite often we're interested in health over time, how it develops and declines across people's life courses, quite often in relation to a risk factor measured at baseline, whenever that might be. And quite often we're using multi-level growth curve models, for example, to model trajectories. But we're also interested in life course transitions. So we have different ways of looking at transitions. We might be thinking about transitions in relation to a social risk factor, for example. Becoming unemployed might be an example. So one method that we often use for that, or we've been using a lot in Equalise, are discontinuity models, which are essentially trajectory models, but modeling trajectories before and after a life course transition is made. If we're interested in multiple transitions, we can use sequence analysis. We had a nice seminar on that recently. Also, Markov models with multiple transitions are increasingly used as well. So we're kind of developing a range of complex models to be able to model various transitions over the life course. And then in life course research, we're interested in pathways or mechanisms that might explain or link an exposure or risk factor with a health outcome. So one way that we've often done this in life course research is through structural equation models. Increasingly, as Yvonne mentioned, causal inference is being used. So things like causal mediation models might be used. I haven't really said much about causal inference here because it is relatively recent development in life course research, but it is increasingly important because some of these kind of questions and methods that we're using are descriptive, just to kind of describe how life courses kind of play out over time. But a lot of the questions we're interested in, of course, are causal questions, as Yvonne was saying. So causal inference is key to that. And I think these kind of path models that we have been doing for a long time in life course research are kind of precursors to this idea of DAGs. So for a long time, we have been drawing conceptual and empirical models about when our exposure happens, when our outcome happens, and what those pathways and mechanisms might be in between, what might our confounding factors be, and now DAGs provide a kind of more precise way for us to do that and test those questions. And then we also have methods that we can probably broadly call data reduction methods. So thinking again about that complexity over the life course, we potentially have a lot of information across a lot of different domains that we might be interested in over many individuals over a long period of time. So we need ways sometimes that we can kind of encapsulate that really complex and large amount of data in a way that's digestible and measurable and manipulable in analyses. So some of those are things, again, like sequence analysis, which kind of can capture information and put people into groups depending on how similar their life courses are. Similarly, latent class analysis is also used to do that as well. So we're going to run through now just some examples of each of these methods, drawing where we can on Equalise members' research. But before we do that, we just also wanted to touch on the kind of key data sets that tend to be used in life course research. This is a little bit fuzzy, apologies. One of the areas, and we've mentioned this a little bit, or data sets that have been really important for life course research are birth cohort studies. And the UK is really a global leader in this area, with the 1946 cohort being established after World War II. We then had the 1958 cohort, the 1970 cohort. So these are studies that follow people from birth until death, ideally. We then had a bit of a gap between the 1970 cohort and the Millennium Cohort, but there are studies that are kind of have served the purpose of filling in that gap. The Next Steps cohort has been kind of revived from an educational survey that was done earlier on of people in the 90s, essentially. And then we have ALSPAC, which is a more regional cohort of children born in the early 90s, and Born in Bradford, again, another important regional cohort in the UK. And we have devolved nation studies growing up in Scotland. And most recently, Children of the 2020s, which is done through Department for Education, linking survey and administrative information. And the early life feasibility study, which has now become beyond a feasibility study and its own kind of new cohort study, which is just getting underway now, called Generation New Era. Which is exciting. And then we've got some studies there along the bottom that are international, but I probably don't have time to go through all of those. And then also panel studies. So these are studies where we have a wider age range of people. They're not all born at the same point in time, but they're followed longitudinally. So in the UK, we tend to use Understanding Society, the UK Household Longitudinal Study, which was built on the British Household Panel Study. And we have international comparative studies that are very similar to that in Australia with HILDA, Germany, the GZUP, and there are others. We've listed the Whitehall 2 study, which was kind of crucial in setting up inequalities in health. Again, don't have time to go into detail, but we can talk about that. And then there's a whole range of aging studies, thanks to largely to a man called Richard Sussman at the National Institutes of Aging, who established the Health and Retirement Study in the US and then made it his life's mission to go around the world and set up equivalent studies in a whole range of countries. And thanks to Morton Warendorf and others who've now put these together at the Gateway to Global Aging, if you want to look at those. Okay, moving on now to some examples of sensitive periods and the importance of early life. Back to Yvonne.
Okay, thank you. We've not got much time.
Sorry.
No, it's okay.
Oh yeah, we're going to speed up.
We're
now.
going to
Quick
speed up.
examples.
We're going to run through these.
You can tell we haven't timed this previously.
Okay, so first example here, thinking about sensitive periods. I wanted to show this because it was a landmark study. The context is 1970s UK. We're starting to understand that lung cancer is attributable to smoking cigarettes, and Neville Butler and Harvey Goldstein, who are legends in Lifecourse research, set about analysing data from the 1958 birth cohort study that Anne has described. They showed unequivocally that smoking in pregnancy was related. On the left-hand side there, you can see to death rates, and on the right-hand side to birth weight. And I'm not going to go into the detail due to time, but you can see large differences there for both of those. So that was a real landmark study, and to this day, that evidence is still used in public health campaigns around smoking during pregnancy. So it stands, it's been tested and replicated multiple times over. Another interesting area in terms of early life is the idea around infant feeding. And there's a whole political agenda and set of narratives around infant feeding, breastfeeding, formula feeding, and so on, that have shaped a lot of the work that we have done. Been working on this for a long time with Amanda Sacker and Maria Quigley and colleagues in Oxford. And a whole range of studies have been conducted to try to isolate the potential causal effect of breast milk in terms of human health. A couple of examples. This first one, makes really good use of the differing distribution of breastfeeding in two different country settings. Brazil, breastfeeding at the time the data were collected. Brazil, the breastfeeding was more common for women with fewer educational qualifications, low incomes and insecure jobs. Whereas in the UK, and is still in the case of the UK, breastfeeding is more common for those women in what we might think of as more advantaged social positions. So being able to net out that potential for confounding by social and economic position, we are able to see a kind of quite a compelling finding that the longer duration of breastfeeding, higher IQ scores are in childhood. IQ there, all of the caveats about IQ, measuring IQ, duly noted, and I'm going to skip past that, not get into it. But obviously these issues are huge. Extending on from that, Amanda Sacker led this work, a beautiful piece of work, if we say so ourselves. I don't know if Amanda's online, where the idea there was extending this idea of kind of cognitive performance and things that might set us up for educational attainments and hence social mobility. So in this paper, data were taken from the 1958 and 70 cohorts, and we see roughly equal and opposite effects, in quotes, in terms of upward social mobility and downward social mobility. Upward, a 20% increase of upward social mobility for those children who breastfed, and a 20% reduction in the odds of downward social mobility for those who are breastfed across the two cohorts. How am I doing?
Yeah.
Okay, next slide.
Very good.
What's this one?
So child self-control.
Moffat. Okay, Dunedin, New Zealand, a cohort of around 1,000 children, looking at financial outcomes predicated on this idea of child self-control. So child self-control measured at age 10, going from low control on the left to high control on the right. You can see this beautiful crisscross pattern, which basically indicates that for those who were designated as having low control, had kind of lower incomes, less financial planfulness, more problems financially, and so on, in their adult lives, so in their 30s and 40s. Okay, next one.
Effect modification.
Effect modification. We're a bit obsessed with this as well. So not only are we obsessed with time, but we're also obsessed with effect modifiers, because they really help us if we think that if we hypothesize that some third factor is going to either buffer or amplify a main effect, so an effect between an exposure and a health outcome, then targeted interventions might follow. For example, if we see a dampening of that main association, or we see particularly vulnerable groups where there's an amplification. This is quite a heavy duty example of effect modification, and I'll be as simple and straightforward as I can. The central association here is between birth weight and the risk of diabetes. In general, children born with lower birth weights or very high birth weights are at an increased risk of developing diabetes down the line, so in the adult years, typically in the 30s and 40s. So we see this reverse J-shaped relationship. We see this a lot in epidemiology when we're thinking about birth weight and how it relates to later chronic diseases. Here, the effect modifier hypothesized in this study was lifestyle score, which I'm not crazy about, but it's a really nice, clear example where we see the unhealthiest lifestyle score on the left-hand side. So 4 of things like drinking, smoking, not exercising, and eating fast food, those sorts of markers. We see that relative to children born in the middle birth weight category who have 4 unhealthy lifestyles in midlife, you see an incremental decrease in the risk of diabetes on the y-axis as you go from left to right as lifestyle scores become quote unquote healthier. So this really do see a sort of a marked step down in the risk of diabetes. Just touching on accumulation, as Anna's already explained, it's roughly an additive approach. This next slide, we were interested in bedtimes, and we produced a series of papers on this. Again, Amanda was involved very heavily in this work. And here we look at the regularity of bedtimes collected in the early sweeps of the Millennium Cohort Study at ages 3, 5, and 7. We look at those against behavioural difficulty scores. Higher is bad. And for both parent rated on the left-hand side in red and pink, and teacher on the right-hand side in blue, you see that with the increasing, relative to children who always had regular bedtimes, you see the increasing number of occasions for which children had non-regular bedtimes correlates very strongly with higher, sort of an incremental step up in terms of higher behavioural difficulty scores. And lastly, from me, another example of accumulation. This is adding up a whole bunch of different exposures from the infant period, so not being breastfed, being low birth weight, a bunch of socioeconomic markers around households, and also living in damp housing and precarious housing, as well as in deprived neighbourhoods. Very simply, we added this up as a risk score, going from left to right on the x-axis there. And on the y-axis, you can see verbal abilities. And the takeaway from this was that children with 0 of these adversities or these risk factors, which was about 25 to 30% of the sample, were on average 8 months ahead of the rest of the cohort in terms of their verbal ability at age 7. And as you go from left to right there, you can see an incremental down step in verbal abilities. Kids with 5 or more risk factors accounted for about 10 to 15% of the sample. And you can see for those with 5 risk factors, they're about 9 months behind. So by age 7, we're looking at a yearly gap of around 18 months or so, just across that risk factor score in terms of verbal abilities, which of course is highly relevant in terms of thinking about policy and reducing health inequalities. Over to Anne for some speedy examples.
Okay, I won't say too much about trajectory analysis because I think people are pretty familiar with the idea of looking at change over time, which is effectively what trajectory analysis does. This is just a schematic of how we are interested in development in early life and then decline with age in Lifecourse studies, and the determinants of that gain in early life, ensuring people reach their potential, and then determinants of loss as they age. Sorry, but we do all lose some at some stage. And here's a quick example I won't go into, but this is actually an MSc student we had who looked at trajectories in health in relation to care by ethnicity and showed that the kind of dominant association we see in the white population actually doesn't necessarily hold over time for different ethnic groups. But what I want to say a little bit more about is this idea of transitions and social exposure. So thinking about those different trajectories before and after a transition happens. And for this, in our work, we've been using discontinuity models quite a lot. And I want to acknowledge Bao and Zhu here because it was actually in her PhD that I first came across this, looking at trajectories in health before and after retirement in a Chinese survey. Here we've used this in the Eurocare project to look at trajectories of, this is psychological distress, before and after people become carers at different stages of the life course. And here we're looking by intensity of care. So that red line is people who are caring for 10 hours a week or more. And you can see that uptick in symptoms of psychological distress between those two lines at the time at which people become carers. So that means more symptoms of psychological distress. It's particularly strong in those midlife age groups. It's starting to happen a bit before people become carers, and it lasts for several waves after people take on care. Thinking about path models, mediator analysis. This is going way back now to Becca Lacey's PhD. I hope you don't mind, Becca. But I think it's a really nice example. She looked at parental separation when people were young in the 1958 birth cohort before the age of 16, and looked at what the different material and psychosocial mechanisms might be over the life course, linking parental separation with later inflammation in midlife. And she tested a range of material and psychosocial mechanisms, and then kind of took out the things that weren't operating in the model. And this is what she was left with. So you can see that kind of strong link, parental separation leading to greater material disadvantage at age 16, which is then linked with educational attainment by age 23, which is then strongly influencing inflammation at age 44, and also working through psychological distress in early and mid adulthood, and a little bit working through parent-child relationships as well. So this is a nice early example of those path models looking at mechanisms. And this I probably don't have time to get into, but here with Peter Martin, we way back when we're looking at bidirectional associations between father and mother reading, which was the indicator we had consistently across age in the Millennium Cohort Study, and child behavioral development. But this is just to show that you can also use these models to look at bidirectional association, something we're also interested in Lifecourse studies. Now people tend to use random intercept, cross lagged panel models, and parallel process models and things that are a bit better than what we did here. But that's also another method that we can use. Data reduction. Okay, I'll just quickly show sequence analysis. So you'll know that we a lot of people know that we have done a lot of multi-channel sequence analysis in work and family life, but this is a little more simple because it's just one life domain, caregiving, and here Enrico in his PhD used sequence analysis to characterize different transitions in and out of caregiving over time for individuals, and then was able to group people who were similar in terms of their caregiving life course experiences. Previous to this, people haven't really been able to look at multiple transitions in caring. So this is good stuff from Enrico. And I think that's it.